Good afternoon, everyone. It's a pleasure to be back with you. And I hope you're finding this summit and series of conversations as illuminating as I have. I'm delighted to have the opportunity to start off day 2 of our proceedings with a few remarks as part of a keynote. As Kim mentioned, I am the chair of pediatrics here at Lurie Children's Hospital and Northwestern University. I also have the privilege of being the chief of community health transformation and overseeing what we call the Patrick M. Magoon Institute for Healthy Communities here in Chicago. This combination of academic and community engaged responsibilities is a way for me to try to connect the research work and the clinical work that happens in our medical center with the community impact that our institute focuses on. As part of that effort, a couple years ago, we started the Tricam Initiative that I'll be saying more about as part of my remarks today. I have nothing to disclose in terms of conflicts of interest. Over the next 20 minutes or so, I'll be talking about a few different topics that will take us on a little bit of a journey through the fundamental challenges that we share when it comes to preventing suicide, understanding what we know, in other words, what are the epidemiologic data, knowing what we understand in terms of evidence from intervention studies, some of which we heard about yesterday from our talented speakers, then speaking about aligning together within a common plan, a plan that we can all agree on and focus on together as we do our different things, we pursue our different interventions that our groups of patients, our communities, and the overall population need us to help with. And finally, committing to our roles together. Before I go any further, I want to acknowledge that there is a very personal role and also a professional one when it comes to addressing mortality. In the audience today, we have healthcare professionals, public health professionals, university and school administrators, instructors, and staff, law enforcement and justice system leaders and staff, as well as many nonprofit organization leaders and staff. We welcome in community members, family members, loved ones and survivors of suicide, and many others. As you see this list, you may fit into more than one of these groups. I encourage you to see yourself and understand your perspectives and perhaps some biases that you have about how best to address the challenge of suicide prevention in our communities. And also to think about the different perspectives that people in other groups may bring to this conversation. Regardless of our perspectives, what I would imagine is true among all of us attending this summit is that we are similarly deeply committed to working on this challenge together. The professional challenge here, and what has really, I think, motivated us strongly at Lurie Children's and in the Tricam Initiative, is that on our watch, the causes of mortality for infants, children, and adolescents in the United States are worsening rather than improving. On our watch, causes of mortality for infants, children, and adolescents differ greatly across different racial and ethnic groups in the United States. And on our watch, as a cause of mortality, suicide is becoming more common for adolescents and young adults. For that matter, it's become more common for adults as well. I try to imagine, as a healthcare professional, saying to the next generation that on our watch, this problem, these sets of problems, got worse rather than better. And trying to explain why that would be and how it was that we didn't find our way to be able to address these problems. For me, that imperative to do better and to hand the next generation of people working on challenges a better situation, in other words, to leave the world better than we found it for the next generation, that is intensely motivating. What's also motivating is that as a primary care physician for children and for adults, I have personally known individuals who have attempted suicide and some who have completed suicide. So for me, this particular topic is a powerfully relevant one as a professional and also as an individual. The Tricam Initiative at Lurie Children's, which stands for Teamwork to Reduce Infant, Child, and Adolescent Mortality, is still a fairly new initiative. We're in our second year that attempts to change the conversation about how we are addressing the leading causes of mortality for all the different age groups from 0 to 24. I say different because the causes of mortality differ substantially as children age into adulthood. For that matter, the causes of mortality among adults differ. But since we're here at a children's hospital, we're framing our focus up through age 24. This effort, more than any other that I've been involved with in my 25-year career, has shaped the connection between research and community impact. And our goal as part of Tricam is to galvanize efforts to change how we think about what is possible and what particular challenges that lead to mortality are more similar than different, and therefore could be addressed through common approaches at the community and at the patient level. As part of Tricam, we are deeply informed by the data. So one example of that is here on this slide, where we take a look at the leading causes of mortality over the period from 2005 to the most recent year of national data available, 2019. And this slide takes a look at 10 to 14-year-olds. You can see on the right-hand side, the color-coded causes of mortality. These are the most common causes over this period of time. You can see that the largest bar is unintentional injuries, what some people would call accidents. Importantly, unintentional injuries includes overdoses or unintentional overdoses, whereas suicide may include an intentional overdose, intentional self-administration of a medication that a person took in order to take their own lives. For purposes of our discussion today, take a look at the size of the purple part of this bar on the left-hand side in 2005 and how it grows from left to right. In addition, take a look at the line at the top of the graph. That is the total level or the total rate of mortality for this age group, 10 to 14 overall. First thing you notice is that these 10 leading causes actually make up about 70% of mortality overall. They are a clear focus that we need to devote our attention to. And especially over time, as we see suicide growing as a cause of mortality, it must draw our attention in terms of developing more and better interventions, because suicide and the growth in suicide is part of what's driving up rather than down the overall mortality trends that we see at the top of the graph. Let's take a look now at a different way to summarize this. So in 2019, there were about 530 deaths by suicide among children 10 to 14. It's the second leading cause of death in this age range. And the number of deaths from suicide was 1.3 times higher than the number of deaths from cancer, which gets a lot more public attention and, frankly, funding attention from government and foundation sources. Another way to look at this is that the number of suicides was nearly equivalent to the number of deaths from homicide, congenital anomalies, heart disease, chronic lower respiratory disease. Think of that as asthma. Those are causes ranked 4 through 7 combined. That gives you a sense of the scale here for suicide as a cause of death for children 10 to 14. Now let's take a look at 15 to 24, similar layout with the leading causes you can see coded there on the right. Unintentional injuries, again, the most common, but take a look again at the pattern of the purple bars from left to right. In addition, as the purple bars have grown, and in fact, as some of the unintentional injury rates, which, as I mentioned before, include overdoses, have grown, you can see that the overall mortality rate at the top of the graph has gone up beginning in 2013, 2014, and has never returned or has not yet returned to the 2013, 2014 levels. We have a lot of work to do. In 2019 then, there were over 5,900 deaths by suicide among youth and young adults. It is the second leading cause of death in this age range as well, just as it is for 10 to 14. And the number of deaths from suicide was more than 4 times higher than deaths from cancer. It was nearly twice as high as the number of deaths from several different causes combined. We can also draw the picture of this burden of mortality for 10 to 24-year-olds in these sizes, what's called a box diagram. And you can see that suicide is the second largest cause here, larger than homicide, larger than cancer, which is the gray box, malignant neoplasms, larger than heart disease. This is a major cause of death that must draw our attention. And of course, it has drawn the attention of everyone on this summit today. Let's now take a look at the concern about deaths by suicide in an older age group, 25 and older. These rates, as you'll see on the next slide, are slightly higher than among the 15 and 24-year-olds. But because there are so many other causes of mortality, especially as we age, suicide is not the second leading cause, but rather the 11th leading cause of death in this age range. Because a lot of our national focus and national funding on mortality is driven by adult concerns rather than child concerns in a rank order, suicide has not drawn as much attention for that reason. However, the number of suicides was higher in 2019 than the number of deaths from other leading causes of death, namely septicemia, hypertension, and Parkinson's disease. On this graph, we can see a comparison of the mortality rate by suicide for the different age groups. And you can see the 15 to 24-year-old group there on the left compared to the adult age ranges. And as was brought up yesterday, the ages 75 and older represent high-risk groups with regard to suicide as a cause of death, something that has not gotten a lot of attention outside of meetings like this one. Now let's focus in a bit more on Illinois. I recognize that not everyone in the summit is from Illinois, but hopefully by going through it at the state level, we'll address the needs and focus area of many of our attendees, and also can set up a pattern of inquiry that can be relevant for other states as well. So across Illinois, for the ages 10 to 24, suicide is the third leading cause of death, still in the top 3, but number 3 here, with homicide number 2. We know that Chicago and Metro Chicago are driving that homicide rate up higher than the suicide rate in our state. And that's something certainly that deserves a lot of policy attention. In terms of the suicide rate for youth, suicide was the leading cause of death among the top group there, the second leading cause of death among youth 10 to 24, and 32% higher in 2018 than a decade prior for youth 10 to 24. What we like to do in Tricam is help these statistics be even more relatable, especially when we're talking with the media or talking with other stakeholders, for example, legislators. So what we've done here is to take a look at the most recent year of data, which for Illinois is 2018. We find that 203 youth ages 10 to 24 died by suicide in that year. That is nearly 8 classrooms full of youth. Or said another way, there was at least 1 death by suicide among youth 10 to 24 every other day in 2018 in our state. In our experience, when we talk to legislators in this way about the burden of suicide, it gets very real very fast in terms of their attention, and is an opportunity for them to gauge what they thought the burden was in many cases compared to what the data are sharing and telling them. Another way to think about this is over 11,200 years of potential life lost in 2018 due to suicide among youth 10 to 24 because that suicide happens so early in life. And in Illinois, more than 1 in 5 youth who died by suicide up through age 24, beg your pardon, this is ages 10 to 17, died by use of a firearm. As many of you know, that availability of lethal means is associated with successes of suicide. Now let's hone in even further down to a county level. I've shared with you the national level, the state level data, and when we look at the county level data in Illinois, we've listed here on this slide the top 5 counties in terms of the numbers of deaths by suicide. You can see that in the next to last column on the right, the county ranked by deaths, with Kane and Lake counties tied at 34. And Cook County, as the most populous county in the state, is clearly the county with the highest number of deaths. However, when you adjust that for the population and you generate that crude rate per 100,000 in the middle of the table, you see that actually Will County is number 1, followed by Kane, which is just west of DuPage County itself, Lake County, which is the county between Cook County and Wisconsin, and then Cook County. When we've spoken with public health officials in these counties, they are very aware that suicide is a major problem in their counties, but in some cases, it's been a surprise where their counties fell in terms of the overall rates in our state. In working with the Illinois Violent Death Reporting System, which is based here at Northwestern, we were able to take a look at some so-called heat maps of, these are for children and adults combined in terms of completed suicides. You see here in the Cook County maps on the west and far south sides, there are hotspots on the west side in the near West Side neighborhood, right near the confluence of 94 and 290, as well as in East Garfield Park. On the far south side, there's a hotspot in Auburn Gresham and also in Ashburn. These heat maps really illustrate a geographic concentration of suicides that otherwise might escape our notice and can fundamentally inform how we reach out to particular communities in distress. Taking a look at other counties, such as Lake and DuPage counties, you can see similar hotspots. In Lake County, just north of Waukegan, out to the west in Round Lake, and then in DuPage County in the Villa Park area. Honing in further to the city of Chicago itself, these are data for children and adults combined from the Illinois Violent Death Reporting System. Now we're looking at data for suicide attempts. And you can see here what many students of patterns, epidemiologic patterns in Chicago will quickly recognize is the map of economic distress, where the west and south sides have the highest frequency of under-resourced families, under-resourced households. And in this case, in this map, you can clearly see are also the areas of the highest frequency of suicide attempts. So taking these patterns together, we have some key observations. We can understand suicide as a cause of mortality within the context of overall mortality by age group. There are opportunities to communicate the magnitude of the problem of suicide to decision makers and policymakers, and pave the way for discussion of interventions. Open the door with those numbers and that imagery of who we have lost. And there's geographic concentration of suicides and suicide attempts, which can provide opportunities to understand the driving factors behind these patterns. Well, if we go from patterns to key observations, then we can get to plans. And we need to ask ourselves, what are the best opportunities to reduce suicide? Is it that we don't know what works, or that we know, but we don't consistently implement what we know? And that was a bit of the theme yesterday, that actually there's really good evidence about what can work, but we may not be implementing it consistently yet. And importantly, how can we combine strategies to optimize impact? When I refer to combining strategies, I'm talking about combining strategies ourselves as organization by organization, neighborhood by neighborhood. And I also mean combining strategies across our different groups, let's say functioning as a county, a city, or a state. Drawing from a recent, very comprehensive review of evidence in the literature about opportunities to prevent suicide, published by Zalzman et al., I identified from their summary some key strategies that really fall into the following categories you see bolded on this slide. At the community level, restricting available means to commit suicide, namely reducing access to firearms and to opioid analgesics. To establish barriers to sites common for jumping. In schools, to have schools-based skills training, opportunities or programs to promote mental health literacy, and to advance suicide risk awareness, peer-to-peer. In mental health care, to have evidence-based, sustained, age group-focused treatment of psychiatric disorders using medications and cognitive behavioral therapy. I say age group-focused because in that older group of adults, medications don't work the same way as they do in the younger and middle-aged adults, and we need to be very cognizant of that as we try to approach the challenge of older age depression and suicide risk. In mental health care, we can also use evidence regarding family-based crisis intervention in emergency settings for adolescents, which has been shown to be powerfully effective. And as we were talking about yesterday, have structured follow-up for individuals who attempt suicide. That safety plan and have it structured in terms of the information for the individual and the follow-up for that individual are very important parts of that particular strategy. And in primary care, we can have collaborative behavioral health care involving primary healthcare services. And we need to do even more than we have already to educate primary care physicians in their targeting and recognition of depression risk and treatment. And we need to help them understand how to screen and tailor interventions accordingly. I would ask you then, how many of these approaches are being implemented in the communities that you serve? What other approaches are you using in your communities? Perhaps that organizations or individuals have found to be effective over time, but might not appear in this list, either because overall they perhaps didn't have as strong evidence of impact, or perhaps they haven't been studied adequately. Because that's one bottom line from the literature, is that we actually need more and better studies of many of these different intervention types. One of the most common things you'll see in the research literature on this topic is that there is insufficient evidence. That really means we haven't done the definitive studies yet about whether particular interventions can be effective for communities at risk. Well, as I'm wrapping up here then, I wanted to celebrate a particular accomplishment in our state, which is a hard-won accomplishment through the efforts of many, many stakeholders. The Illinois Suicide Prevention Plan was published just last year, and if you have not taken a look at it, I really encourage you to download it and go through it in some detail. I'm going to highlight a couple aspects here that I think really show us how valuable a document and how valuable an effort this can be. It begins with a summary of recommendations, several of them, but I think strategic direction number one really summarizes it very well. That suicide prevention should follow a public health model that provides a role for all elements of our community. We cannot leave out any stakeholders who want to be involved, and even some stakeholders who can't quite see their role. I'm optimistic we can help bring them in to the suicide prevention efforts. We can integrate and coordinate suicide prevention activities, utilize communications to help change attitudes and behaviors, in other words, achieve culture change, increase understanding of protective factors and how to promote wellness and recovery, and promote responsible media reporting of suicide, which shapes public opinion. As this page shows, the Illinois Suicide Prevention Plan provides particular guidance for many different stakeholders. So you and your organization can find yourselves in one of these groups or read over several of them and see where or what resonates with you in terms of potential suicide prevention opportunities that you can follow through on. And very importantly, and this approach was discussed yesterday, Objective 8.1 in the Illinois Suicide Prevention Plan is to adopt zero suicide as an aspirational goal. The idea of zero suicide is to screen all patients for suicide risk, assess the level of risk of patients that screening indicates are at risk for suicide, and provide intervention appropriate for the level of risk. We can refer patients determined to be at risk for suicide to treatment and community resources, and ensure immediate and continuous follow-up after discharge for patients determined to be at continuing risk for suicide. The bottom line of judging the evidence about intervention, understanding what we're doing today, and then thinking about what we can do tomorrow is that as an individual or organization, we can find ourselves in the coordinated statewide plan, whatever our state may be. We can consider which recommended practices you can implement, how to be a part of that approach. Collaborate and coordinate with others who are already involved, and communicate about your efforts and your impact. The public needs to know that you're working on this, that you care deeply about it, and the effect that you're having so far, and how much farther you want to go. And finally, we all need to commit and support each other in sustaining our engagement so that we can reduce suicide to zero. Just a few words here at the close about how we at Lurie Children's are responding. I described Tricam already, and Tricam is trying to bring together multiple efforts at once by nurturing and fostering communications among folks who haven't necessarily worked together before, but are finding their common commitment to reducing suicide to zero is a fundamental connection that they have with others. You see that zero suicide implementation is something that we've adopted as an organization. On the left-hand side of the screen, across our clinical and quality areas, we are committed to the National Patient Safety Goal that you heard about yesterday from our Joint Commission colleagues. In education and advocacy, we have our pediatric residents who are involved in an advocacy committee that's involved also in suicide prevention and promotion. And we also have faculty-initiated research, and Dr. Jennifer Hoffman is one of our leaders in this arena, and she's going to be one of our contributors later on this afternoon. The Zero Suicide Collaborative that we're participating in, sponsored by Cardinal Health, brings together 17 different organizations, of which 6 are children's hospitals. The idea here is that these healthcare organizations that have a particular role to play can coordinate and commit to getting to zero. This goal of zero suicides requires special dedication, not only to the interventions, but to culture change, because talking about suicide is not really a popular topic in healthcare circles, or it hasn't been. We need to help change that dynamic in order to have different and more productive conversations about what our institutions' roles can be. So we have multiple components and coordinated efforts across clinical care, where we're embedding evidence-based approaches. The measures, namely patient outcomes, measuring how closely our staff are following the interventions, called staff fidelity to the interventions, and measuring workforce competence and confidence over time as we regularly talk about getting to zero. For quality, we're conducting continuous quality improvement to improve our performance in this arena. And as I mentioned, we're focused on the necessary culture change to normalize suicide prevention and care practices. I mentioned Dr. Hoffman, Jennifer Hoffman, in our emergency department here, who has published on pediatric suicide and factors associated with pediatric suicide in ways that are helping change our focus and help us understand the best data about where we need to find communities at risk, how we need to relate to them, and ultimately, how we're going to intervene most effectively. This type of research is really critically important to continually helping to inform interventions as they go forward. Importantly, Tricam as a program within our organization is connecting to other suicide-focused individuals and organizations outside our organization as well. And in fact, that's what led to the summit that we're having today and yesterday. Through that effort, we've been delighted to make some new friends and hopefully very long-term partners in the drive to get to zero suicide. So that concludes my remarks. I know we're about wrapped up here for the keynote, Kim. Again, I welcome you here to Lurie Children's and to the Northwestern campus. It's a delight to have you all here. I hope that my address was a help to you in thinking about the evidence, the intervention opportunities that differ by organization and by community, and ultimately the common goal that we share and the commitment to reducing suicide among all the populations that we serve. Thanks very much.